And we are live. Welcome, everyone.
Welcome.
Hi.
Welcome, everyone, to the Melanin Initiative. I'm Alicia Brown and one of your co-hosts for the Melanin Initiative podcast. In healthcare, there's often too much information and not enough time. Here at the Melanin Initiative, we avoid TMI by breaking things down into language you can understand. We create a safe space to ask your questions and share our nursing perspective without taking too much of your time. Today, we'll be talking about sickle cell disease from the patient perspective and what it means to live with chronic pain, with emphasis on disparities in pain management. Geraldine had a previous engagement, so she's unable to join us today, but she sends her love. So by the end of this episode, we hope you'll be able to talk about what sickle cell disease is, name risk factors for getting sickle cell disease or the genetics, discuss diagnoses and treatment options, understand what it's like to live with chronic pain, name common symptoms associated with pain medication, opioids specifically, and talk about some disparities in pain and what clinicians can do to improve. So as always, our disclaimer is that this show is for educational purposes only. The opinions expressed are our opinions alone. They are not a representation of any of our affiliations. If you are experiencing a medical emergency, you should seek medical attention and medical guidance from your healthcare provider. So this episode, we have a special guest with us. Her name is Alyssa. Alyssa and I actually went to nursing school together. So I'm actually very excited to have her join us today. It's like full circle, you know, when you meet someone at that time of your life, we probably were 18, 19. And to
Around
see
that age.
Right. To see where we are now. And I knew that you were going through this journey in your life. So I thought this was a perfect time to have you come on this episode with us as a nurse and also as someone who has sickle cell. So welcome. We are so happy to have you join us.
Thank you so much.
Yes, thank you. Thank you for inviting me.
Wonderful. Yay. So usually on the Melanin Initiative, we always start off with the definition. So in your words, Alyssa, tell us what sickle cell disease is.
So sickle cell disease is a blood disorder that is hereditary. It doesn't just come out of nowhere. And with sickle cell anemia, where you have the normal red blood cells that are more circular shape, with sickle cell, they look more like a banana or a crescent moon. So with that shape, they can have low oxygen. It can cause for, instead of like the blood flowing through your veins easily, it can kind of stop in the vessel and cause clotting, which then causes extreme and chronic pain.
Thank you. So who is typically at risk for developing sickle cell anemia?
The population that's more at risk of having sickle cell anemia is more of the African American descent. And mostly with if you have sickle cell anemia, that means that both of your parents had the trait, or it could have one of your parents had the full disease while your other parent had the trait.
And so, and here in our slides that here you can see the two parents. We have the mom and the dad. They had 4 children. So each parent had one portion of you need 2 genes to have sickle cell. They have 1 each. So when those 2 come together in the last child there that's completely in blue, you can see that they have sickle cell. That's what we call recessive trait. Both parents have to contribute.
Yep, absolutely.
So Kimberly, if you could go back to the symptom slide, we could see that sickle cell anemia, when you are going through a crisis, there's different types of things that you may experience.
But before we jump, I don't want to ignore the other, because people are probably like, what about the other kids? And so
I thought you were going to go there, but okay.
It's all white. They didn't get either of the gene, so they can't pass it on.
Yes, which can happen.
Right. So their kid won't get it because the parent, you have to get one from each parent. Now, the 2 kids in the middle that are half shaded blue, if they have a baby with someone who's also half shaded blue or recessive, then their kid can end up with sickle cell. So we would say that they have the trait, they don't have the disease. Okay. And if you have questions about that, you can send us an email.
Thank you, Kimberly. So as you can see on the slide, some symptoms of sickle cell anemia include fatigue and decreased hemoglobin, which is the level of blood in your body, eye damage, bacterial infections, bouts of pain, leg ulcers, thromboses in the spleen and liver, which are clots, swelling and inflammation of the fingers, toes, and arthritis, pulmonary and heart diseases. So, Alyssa, a little bit of a personal question, but how did you originally get diagnosed with sickle cell?
So I got originally diagnosed way before I was even born. So my mom actually, because I'm one of three, so my parents knew that one of their children were going to have the full disease. So my mom went to her OBGYN and got tests done and found out that I was going to be born with sickle cell disease. So before I was even born, she already had a plan of how to not really handle it, but more so like what to expect in the future so she could prepare herself so it's not like a shocker when they do the newborn screening and you find out from that as well.
That was an excellent question, Alicia. So actually now I'm curious, did your mom or dad have sickle cell? What made them originally even get tested themselves?
So both of them, so of course with I believe it's also with prenatal testing. You guys can let me know if I'm right or wrong. They do test you for the sickle cell trait as well, or if you also have the disease, if you don't know yourself. So my parents already knew that they both had the trait. So
you're the oldest, I guess. Where do you fall in line with those other kids?
I am the middle. So my oldest sister, I have two sisters. So my older sister, she has the trait. I have the full disease, and my younger sister doesn't have it at all. So it's going back to that chart, yeah, just like the picture, it literally was like, what do they say, like 33% chance, and I just happened to get it.
Wow, that's so interesting. I mean, we see this, we hear the science behind it, but then to see this in real life, that this is actually what happened in a family, it's very interesting to hear. So yeah, you got diagnosed prior to even being born. What, if you could think back, what was your first crisis like? What do you remember that? When was that? How old were you?
I want to say I think I more so had more of a pain crisis when I was in about, I want to say 10 or 11. I know definitely it was more like I could tell the difference between like regular pain, like, oh, you have a headache, or just like back pain or anything. But when it came to, oh, this is a sickle cell pain crisis, I would know because once I was like 10 or 11, I would have pain almost like in joint areas. I would mostly have it either in my lower back or in my legs or in my arms, like around that period where I'm going through a growth spurt. And I was constantly in and out of the hospital. And that's when I was like, okay, I can definitely differentiate. That is not how you say the word, but you guys know what I mean. Know the difference between like regular growing pains and sickle cell pain. So around, sorry, go ahead.
No, go ahead.
So around that time, that's when I remember at least my first sickle cell pain crisis when I was about 10, 11 years old.
I thought you were going to say something younger. In this picture here, we have the healthy red blood cell, which is that coin disc shape. It flows through the artery, no problems. Now, see those sickle cell ones, you see them all clustering up, right? And so we remember that we've talked about before, blood cells carry oxygen and nutrients. And so when cells can't get oxygen or nutrients, you have pain. And so when they're referring to crisis, I guess, how do you describe what a crisis is for you?
For a crisis, for lack of better words, I would say it's excruciating pain. It almost feels like I can't move sometimes because I'm trying to get in that comfortable position to like get the pain to calm down. And it does radiate. So like if it starts the pain in my back, all of a sudden it can move to my legs, or it can be in both areas at the same time. And with treatment at home, like when I would have pain, I use heat. Not everybody uses heat, but I use like a heating pad. I can put it in one area. If it moves to a different area, I can't move the heating pad in both areas. So that's where I'm like, okay, this is a pain crisis. Yeah, that's mostly it.
You always go to the hospital for your crisis?
Not always. When I was younger, yes, because it was still new to me and new to my family on how to help with treating it at home. And of course, it's like trial and error. Not, I wouldn't say trial and error, but it was more so for my doctors to figure out what's a good dosage for me pain wise to take at home. So sometimes I would go into the hospital, and other times I could be treated at home with like pain medicine, which I can take over the counter, like Motrin or Tylenol, and then like prescribe narcotics, whichever narcotic my hematologist would prescribe to me.
Oh, okay. So before we move on to hematologist, I just want to run through these symptoms one more time. So because we talked about red blood cells carry oxygen and nutrients, and then we start to look around the body, well, what happens when they don't get that? So the fatigue, that's why, and it's anemia. All types of anemia typically are associated with that feeling of fatigue or feeling tired, sluggish, because those organs aren't getting oxygen. Infection. Have you had to deal with any infections?
I did have to deal with infections almost, I would say, majority of the time when I would feel a pain crisis coming on. If they would always run tests if I have to go to the hospital to see if an infection is the reason that the pain started. And sometimes it would be because of an infection, like the most recent, like pneumonia, if I would have that, which leads into like acute chest syndrome and all that.
Yeah, so anytime the blood sits in one place, whether that's inside the body or outside, it has a tendency to attract bacteria. And when your blood's already not flowing, it just makes it even more complicated to treat. Leg ulcers, again, you're not getting oxygen or nutrients to those tissues. Same with blood clots, the blood's sitting, right? And so that can happen. You can get that clot anywhere, both in the lungs, the heart, and any organ. And then she's already talked about those bouts of pain. And the eyes super tiny. Just the slightest lack of oxygen, you're going to start to see some problems there. Yes. Okay, you brought up hematologist. Do you want to go in that direction?
Sure. So with my hematologist, of course, they keep a close eye on me. I would see them when I was younger. I would almost see them, I want to say every month or every 2 months, because I don't want to give my age too much, but they didn't have much research back then with sickle cell. So they would always have do research opportunities that we would try to see what could help with the pain, in a sense of finding a cure for sickle cell. And also around the time where I would start having pain crisis, I also started getting blood transfusions almost monthly. So that's when I would see my hematologist the most. They would do, I'm trying to find an easier word to say this, but you guys would know. It would be a transcranial Doppler. So like an ultrasound on my head, where they would look, because we are at risk of having a stroke because of those blood cells being that crescent shape. So they will always do that ultrasound, especially at a young age, to make sure I'm not at risk of having a stroke. And if I was at risk, that's when the blood transfusion started for me, which I did for maybe, I want to say 2 to 3 years until I transitioned. So then I would transition into just taking, right now, hydroxyurea, and I've been taking that since.
Oh, perfect.
Yes.
We have to thank Geraldine for putting these slides together for us this week.
Yes.
Oh, look at that. She already had it on there.
Look at that.
And so a hematologist, they specialize in all your blood cells, white, red, platelets, and any complications. They see kind of the complicated cases, right? So our favorite primary care, they're going to see you're having these problems, and they're going to refer you over to hematology.
Yes.
So who prescribed? We promote primary care heavily.
Yes.
Care, because we know it decreases the cost of care It helps people avoid complications, helps them stay out the hospital, and that's where they're going to get a lot of their education. So, yeah, we're big proponents of primary care here on the TMI.
Oh yeah, absolutely.
Who prescribed your Hydroxyurea? And it keeps them at the emergency department. That's a huge part of it, right? Because it's full of people who need to be there, and some of the people don't need to be there. So we want to save them their time too. Who prescribed you your Hydroxyurea?
So my hematologist prescribed it for me. My primary care, of course, they see all different types of illnesses and diseases. But when it comes to the hematologist, they know more in depth of what the medication can do. So my hematologist prescribed the Hydroxyurea for me.
Okay. Do you want to just tell us a little bit about what it does and if you have any symptoms and what you tell your patients?
So with the Hydroxyurea, it does help, in layman terms, it does help with decreasing my pain crisis. Another fun fact, it is considered a chemotherapy drug. Most people hear that and they're thinking, oh my gosh, I have sickle cell and cancer. No, that's not it. It just happens to fall within that umbrella. But Hydroxyurea does help with reducing the likelihood of having a pain crisis. It could make that not true hemoglobin, but it's almost called like fetal hemoglobin. So it helps with that. It can help with my blood count. And then, of course, like the symptoms that I would normally have with sickle cell anemia.
And is this something you take every day?
Yes.
Any
so
symptoms?
I would I'll take it about once a day. That's what I was prescribed for me. Of course, everybody takes it differently based on what their hematologist prescribes for how often they should take it.
And like, do you have to avoid alcohol, or is there any kind of things you have to keep in mind when you're on it?
I do have to avoid alcohol. They don't say anything about you can't drive while taking it or anything. Of course, like every other chemotherapy drug, if you have like any body fluids or anything, of course, close the toilet lid when you're flushing and all that, because you don't want, the particles of course, your urine, but also the medication getting in the air and spreading to anybody else.
Good point.
But other symptom-wise, I haven't had too much symptoms. Of course, my hematologist always tweaks my dose a little bit based on how often I have pain crisis. Because if I'm taking it and I'm still having a bunch of pain crisis, they will either increase the dose or do more studies to see like what else they can do to help with my pain.
Okay.
Wonderful. So since we're on the topic of treatment, I do want to ask you, what has been your experience in the hospital setting when you have been having a pain crisis? Kind of walk us through a time that has stuck out for you.
I feel like every time stuck out for me, mainly because, before becoming a nurse, I wasn't too involved because, of course, I was younger. My mom was more involved, but I would remember like the pain. And then, sometimes in hospitals you have good experiences and bad experiences, or you hear two different doctors saying two different things, and it's kind of like up in the air. So in the hospital, I would say as I was a child, I did have more good experience than bad. So they would help with giving me fluids. They would put me on oxygen because, of course, with that crescent shape of the sickle cell, it means low oxygen. So they would give me oxygen just to help, even if my oxygen levels are good. And then they would also give me the pain medicine through my IV, which would be narcotics. So that could either be Dilaudid or it could be morphine. Normally, it's always between those two that they would prescribe. For each sickle cell patient, it is different. So for me, I can take either morphine or Dilaudid. It doesn't really matter for me. But for others and other people I know with sickle cell, sometimes morphine works better, Dilaudid doesn't work at all, or vice versa.
Yeah, I've seen that.
Yep.
Yep.
People come in with their prescription.
Yes. So when in those cases, that's why most sickle cell anemia populations, you'll hear, oh, they're drug seeking, but it's more so they're advocating for yourself, like, hey, I know this doesn't work for me. I'll prefer if I could get this. So I try to tell other clinicians to keep that in mind, like, hey, they're not drug seeking. They're just telling you, like, hey, Dilaudid doesn't work for me. Do you have morphine? Or hey, morphine doesn't work for me. Do you have Dilaudid? More so in that case, like they just know what works and what doesn't.
So, has a nurse changed your perspective or any feelings you have regarding sickle cell disease, or how's your experience changed after becoming a nurse?
I would say it changed slightly, only because most things I already knew, but other, of course, going through nursing school and so forth. Of course, Alicia, you would know with me. In nursing school, when they would go on to sickle cell degrees, we probably had like a paragraph in the textbooks. So there wasn't really much knowledge that nursing school gave me, but of course, being in the field and being more hands-on and working with the physicians, it definitely taught me more of, okay, this is why this medication works, and this is why we followed this protocol for this, and like how many doses they give you in an outpatient setting as opposed to in the hospital, why they escalate to a PCA pump, or if they continue doing IV pushes where they just push through the IV instead of having like a machine where you click a button. So with that, I would say, slightly. But of course, taking care of other patients with sickle cell myself, it definitely helped them a lot more because they can't come to me and say, you don't know what I'm going through, because once they find out, then they're asking me questions like, okay, so what do you normally take at home? What helps for your pain? How often is your pain? Especially the parents, since I work with younger children.
Yeah, that was gonna be my next question. Being a nurse, how has that shaped you taking care of sickle cell patients? How's that changed your advocacy for them?
It's definitely changed my advocacy a lot because, being a patient, you really don't know what's going on. And you might think you're getting prescribed something like a medication and you're realizing it's not helping. So we can get a little frustrated because, you're in pain. Anybody in pain for a long amount of time gets frustrated after a while. So it has helped because if there's ever like another nurse or another doctor that's just like, okay, I gave them this many doses of pain medicine. They said it's not helping. Like, even if it gets on the side of, are they just abusing the medication? I'm just like, you might want to rethink that. Like, just go over, like, why is it not helping? Like, where they say the pain is and so forth. And also, it helps the patient a lot because it's almost like they have another advocate outside of their family that's helping them out as well to like show them like, hey, they're not lying about this pain. They actually have this pain.
Absolutely. Kimberly, do you have any other thoughts?
Yeah. So do you notice if you have any certain triggers that brings you to having a crisis and having to go to the hospital, like dehydration or?
Yes. So definitely dehydration, like you said, high stress. So of course in nursing school, Alicia would know I would be in and out because of pain crisis, because nursing school is hard. And underlying illnesses can also trigger a pain crisis as well. And for me, more so in my adult life, it will be the weather change. So living in Maryland with that weather change can be a lot. So if it goes from like winter to spring, that would sometimes cause it, or like even just fall into winter can cause me to have a pain crisis. I wouldn't be hospitalized for too long, but I would definitely know that would be a trigger.
Okay, yeah, I'm glad you brought up hospitalization. So from my nursing perspective, I have a patient, typically they're African American. Pretty much I have more women than men. And mostly 30 and younger. That we used to have a guy come all the time who was in his like 60s. Remember that guy?
Yep.
But he was really, I think I can only count maybe 2 men really who I really saw on a frequent basis. It was mostly women, young women. And, every time they come back, like you said, pain is uncomfortable and you get really frustrated over time. So they are well known by the staff and not always received with open arms because of that drug seeking conversation that keeps getting passed around. They're just here for that. So, the first thing we do is we get those fluids on board because like that picture we showed, the blood is trying to stay in one place and we need things to keep flowing. And basically every morning we're taking their blood to see when this sickling is done. And technically that's when the doctor starts to come on board and say, okay, they don't need this medicine.
Go home, right?
They don't need
Yep.
And we don't really wean them off because they're just going to go back home and resume that opioid that they were on, right?
Right.
And so, yes, they come in with their prescription. They tend to eat all the time because they don't want to fall asleep and miss that dose, right? Especially if they're calling the nurse for the push. I don't know that I remember too many of them being on a PCA pump.
I see that a lot now.
Oh, now?
Yeah.
Okay. And then that'll get taken away. And then they pretty much go home after that. And I know I don't know if it wasn't in that picture, but sometimes they'll get like necrosis of the hip. And then that's debilitating. And these are really young people, like 20s, 30s, having to have orthopedic surgery, and it's impairing and of course that brings on more pain. So that's been my perspective, is that whole disparities in pain, right? Because it's well documented in the literature when it comes to Black and Brown communities that some clinicians are taught and believe that Black and Brown people have a high threshold for pain, have thicker skin physically, and therefore don't require the same dose. So while one patient might get a prescription for 10 milligrams of oxycodone every 4 hours, a Black and Brown patient might get 5 milligrams every 6. And when I see that for the same diagnosis, I do start to question what's going on here, right? And so any thoughts on disparities in pain management and what you want other clinicians to know?
My thoughts on that is definitely, especially to sickle cell anemia patients. I know some of them can tolerate pain a little bit better than others, but it's still pain. So, and definitely I would say for clinicians to definitely get more knowledge on it. I know there's not too much textbook wise on it, but of course, we're still growing, and now they're still making more research studies and there's more on it. I would just say, just like every other disease, like look more into it. Definitely don't downplay it, because like we all learned, and for being a nurse, being a doctor and so forth, pain is subjective. So you can't look at somebody and be like, oh, they don't look like they're in pain, because sometimes you can be in a lot of pain and just fall asleep, which I've done plenty of times. So in those cases, I would say definitely listen to the patient, listen to their family members in the room, because of course their family members can be a very good advocate for them as well. Even if they get really loud or rude with you, still listen to them, because it can be a lot. They don't like to see their family member in pain. So a lot of emotions. And also just, it's more so knowledge, because there's been times, me as a patient, I'll get one doctor that knows everything and how to treat me, and then I'll have others that would say things that are a little bit alarming, like, oh, you don't need fluids. And I'm just like, huh? So definitely just don't pass it off as, oh, it's just a disease. They will always have pain. And of course, that drug-seeking conversation, like you said, is more so just to be mindful about, like, pain is pain, and you can't predict how bad somebody's pain is just by looking at them. You just have to believe that they're actually going through this pain, especially if you constantly see this patient over and over.
Yeah, and we know that, and when it's acute pain, like something that's going to pass, this is going to be temporary, there might be an increase in the heart rate. They might be breathing faster. They might be sweating. You might have physical things you can look at, but we know that when people have chronic pain, they don't have those changes anymore. So you
Right.
really do have to, it's really going to be the words that they're telling you, and you have to trust them. Lastly, before we close out, because you are a mom, anything you want to share about that experience and any anxiety you had about passing on the trait or your pregnancy itself? Were you considered high risk?
I was considered high risk. So I saw, of course, my regular OBGYN, and I also saw a perinatologist, which in layman terms is a high risk OB. Um, with that, I did have a lot of anxieties. It was more so making sure I was okay, but also making sure my baby was okay. And of course, when you're pregnant, you can't take ibuprofen, of course, Motrin or Advil that you guys will hear. So dealing with that and having sickle cell, of course, with Motrin being an anti-inflammatory, it was hard during the pregnancy because all I could take was either the Tylenol or the narcotics, and of course, that wouldn't last for long. And also during that pregnancy, I would have a lot of blood transfusions because, of course, babies take blood from you, and it's with sickle cell anemia, patients getting pregnant, that can be a lot. Of course, already if your blood count is low. So, with her getting the sickle cell disease, I really didn't have too many concerns, only because my husband doesn't have sickle cell at all. He made sure he got tested, found out he doesn't have it at all. So I knew at most she would have the trait. But it was more so just making sure I kept those appointments with my perinatologist, going off their recommendations, seeing if I needed to go on bed rest early. And I did ultimately get induced as soon as I hit full term. They weren't going to do it by chance. They were just like, we're going to induce you. And they definitely did not want to do a C-section. Of course, in emergency, if they had to do one, they would. But they were just like, we are going to try to stay away from that because, of course, more blood loss with C-sections than there is with vaginal deliveries. Yeah, overall, like the delivery process was great. It was just more so getting through the pregnancy. So for anybody out there that is trying to, of course, like females with sickle cell anemia, if you are trying to get pregnant, it is possible, of course, listen to your hematologist and also listen to your OBGYN if they recommend it's good for you, because each case of sickle cell anemia is different. So I would say just look out for that. You will probably have either more pain crisis, or sometimes you can have no pain crisis at all, because I have met other people with sickle cell that got pregnant. They were fine the whole time. It wasn't until after the baby came, their pain came back instantly. So yeah.
Wow, this has just been amazing, Alyssa. I could think of while you were talking, I was thinking of a billion other questions, but our time has come to an end. I just want to thank you so much for joining us today.
Yes,
So,
absolutely.
just for a reminder for our audience, today we discussed what happens to your body when you have sickle cell disease. We talked about risk factors for getting sickle cell. We discussed diagnoses and treatment options. We hope you understand and kind of can put in perspective what it's like to live with chronic pain. Name some common symptoms associated with pain medications, especially opioids, and the disparities in pain and what clinicians can do to improve. So we kindly ask that you subscribe and share our content. Follow us on YouTube, Instagram, and TikTok. The links to our social media accounts are in the show notes, along with any resources relevant in today's episode. Once again, thank you so much, Alyssa, for joining us today.
You're
Very
welcome.
you. My nursing school sister.
Yes.
As season 1 comes to an end in July, we'll be back in October with some special episodes for breast cancer awareness and officially kicking off season 2 in November. We'll continue to be active on Instagram and TikTok. You can still send us emails, your questions, and we will answer those in our One Topic at a Time series here on YouTube and through our other social media platforms. You can find our email in the description box. So for now, that's it, everyone. Ta-ta.
Alyssa. Thank you, everyone.
Yeah. Thank you. Bye.
Bye for now.